So hi, I'm Dr. Steve Blatt, Medical Director for Infectious Diseases for TriHealth. And tonight we're going to talk about COVID and answer your questions and see if we can put to rest some myths and perhaps help everybody learn a little bit more about this disease that's changed our lives more than any other in the past 100 years. So at this point, I think we will just launch right into questions. I'm happy to give a little background if people want to hear about that. So basically, as everybody knows, in late 2019, December of 2019, we started seeing some unusual reports of a severe pneumonia coming out of China. And eventually, the lid was blown off that by a physician who was working in a hospital in China. And he was noticing all these young, healthy people coming into the hospital, getting put on ventilators, and many of them dying, which was distinctly unusual. And so he started reporting on this over Twitter and other social media events, and basically was shut down pretty quickly. Unfortunately, he acquired COVID and subsequently died from it there within the next month or so. And so, tracing it back, it looks like the first case of COVID that was diagnosed was around December 1st, 2019, in the hospital in Wuhan. And subsequently, there were probably 15 or 20 cases in December, and then it really blew up into hundreds of cases in January. And the disease spread very quickly throughout the whole Wuhan province and then outside of China into Thailand and other areas in Southeast Asia, and subsequently showed up all over the world. And so by about February or March, the World Health Organization declared an international outbreak, a disaster, and subsequently we had a pandemic. In the U.S., the cases weren't really recognized until February, March timeframe, but they were probably here very early in January, going back some blood tests in areas like New York City and San Francisco and areas where people come from Asia with international travel. The disease had been here circulating for some time before it was recognized. One of the big problems early on, of course, was we didn't have enough testing. The test reagents that the CDC put out initially were not good, and that set us back at least a month between March and April, and so we had a lot of cases, but we couldn't test for it. Subsequently, testing got ramped up, and it was pretty clear that we had a surge of cases in the March-April timeframe. Then it kind of settled down a little bit until the 4th of July. Following the 4th of July, we had a big outbreak with surge in mid-July. Then it settled down again, and it was relatively quiet. And then, like in August and September, we didn't have very many cases in our hospital systems, only 15 to 20 cases at a time. And then Thanksgiving hit, and as everybody knows, following Thanksgiving and Christmas, we had a huge surge, the largest one we've had. And so within our TriHealth hospital system, in late December and early January, we had up to 200 cases in the hospital at a time, many of them on ventilators. And our hospitals were really under a lot of stress. But over the last 3 or 4 weeks, we've subsequently seen a significant decrease in the number of cases in the Cincinnati area. And so fortunately, it seems like the local epidemic is starting to wane a little bit, which is a great relief for everybody living in Cincinnati and for our healthcare systems that are under the gun to provide outstanding care in the middle of this pandemic situation. Interestingly, if you go way back to January of 2020, when the epidemic was first recognized, the Chinese were able to isolate the virus and publish the genetic sequence of this coronavirus within about 3 weeks of the first cases being recognized in Wuhan, which is really dramatically fast in my estimation. And so we've known the genetic sequence of this virus, and within a few weeks after it was published, vaccine manufacturers were already developing a vaccine. So Moderna and BioNTech, which is the Pfizer vaccine, those companies were already starting to develop a vaccine based on this mRNA technology. And those vaccines, were initially tested in early phase 1 studies to make sure they were safe, and then phase 2 studies to make sure they developed immunity in patients who got them, and then eventually very large phase 3 trials involving 30 to 50,000 patients in each one. And they've subsequently been shown to be very safe and very effective. Fortunately, both the Moderna and the Pfizer vaccine are over 95% effective in preventing COVID infection, which is really an amazingly good effectiveness of any vaccine. So this mRNA technology had been out there for many years, and it was actually being used to develop cancer vaccines. But it got switched over very quickly to develop vaccines for COVID, and so far it's working very well. One of the biggest problems we saw during the surge in both the summertime and in the December to January timeframe was the patients who were older and frail living in nursing homes were getting infected at a very high rate and subsequently passing away. But since we've been able to vaccinate all the patients in nursing homes, that problem has almost completely been eliminated. We hardly ever see cases from nursing homes now, and we almost never see people die in the last month or so from nursing homes, which is just a dramatic improvement in the outcomes of patients who get COVID. The other thing that's interesting about this epidemic or pandemic is it's so severe on the older population and hardly causes any symptoms in younger people. There are a few children who've come down with COVID who get this unusual multi-system inflammatory condition, but that's very rare. And so that's part of the reason why this disease has been so hard to control, is there's a lot of asymptomatic infections in young people. Teenagers, 20, 30-year-olds who don't get very sick, they don't even know they have it sometimes, and yet they're able to spread the disease. And that serves as an ongoing reservoir for new infections in the community. Older people tend to get more symptomatic, they tend to get tested, and they tend to know they have the disease. And so they can be quarantined or isolated if they have the disease, and their contacts can be quarantined. But if you're young and healthy and you don't know you have the disease and you're spreading the disease, and all your friends who are young and healthy don't know they have the disease, it's really hard to control this pandemic. So that's been one of the biggest problems, is probably 40 to 50% of all the infections have never been formally diagnosed because people are asymptomatic. So there are pros and cons to that. So the bad thing is it allows people to go on and spread the disease. The good thing is most of those people are at least immune for at least some time. And that's one of the reasons why we think we're starting to see the number of cases go down, is we haven't quite yet reached what's called herd immunity, where the whole population is immune, but at least a subset of the population is probably immune. So there may be a large proportion, maybe 30 to 40% of the young people who are relatively immune to this disease already, and they can't catch it and they're not able to pass it on. And so therefore we're starting to see the number of cases go down because a smaller and smaller proportion of the population is susceptible. We're not going to stop the pandemic if only 30 or 40% of the people are immune, but at least it'll slow down. And I think that's what we're seeing right now. And so the big question right now is what's going on with these variants or mutants. So there have been a number of new variant strains identified, first in the United Kingdom, and then Brazil and South Africa, and now even in the US, there's a Southern California strain that's been identified. And a number of these strains, particularly the United Kingdom strain, seems to be able to spread about 30% faster than the original virus, and maybe about 50% more virulent or deadly than the original virus. So as these new strains come along, the big question is going to be, are our current vaccines going to protect us from these variant strains? And there's a lot of research going on right now trying to identify whether we'll be fully protected from the variant strains based on our current vaccines. So I think at this point we can probably take some questions or.
You mentioned a number of questions coming from our team. So
okay.
I apologize if they're goofy or that. But
no, that's fine.
We're trying to get people comfortable with the vaccine.
Right.
So you mentioned 30 to 50,000 patients in each one of the tests. How does that compare with a normal drug test? I mean,
Well, that's actually a lot more than a normal medication trial, typically.
A popular medication, and how many would you assume? So I can do it. So we can do a comparison for people to say, hey, it's.
Yeah, a lot of it depends on how effective the medication is, and there's something called a power analysis you have to do. So many medication trials may only have a couple thousand patients in them, and you can, identify a statistically significant difference in the treatment and placebo groups with a few thousand patients. In a vaccine trial, it takes a lot more to do that, but you get to the answer a lot more quickly the more people you put in the trial, and depending on how many cases are occurring in the community, you get there quicker too. So with COVID, they were able to do these clinical trials within about 2 to 3 months because there was a huge burden of disease in the community, and they enrolled so many people that we could get to a statistically significant answer very quickly. So that was one of the reasons why these studies could be done. Now, if it was a rare disease like Ebola, it takes years to get to that number of cases to prove that a vaccine actually works, unless you're in the middle of a major outbreak.
And now with millions that have been vaccinated around the world, from your perspective, how safe do you feel the vaccines are?
I think they're really safe. I mean, we have not seen any unusual, unexpected side effects so far. The major side effects are that which you would expect from any new or any kind of vaccine, really. You get a little feverishness, you get a sore arm, you might feel achy for a day or two, very similar to what you get with the flu vaccine. Early on, there were some reports of anaphylaxis, which is a severe allergic reaction in people who are highly allergic to things. And so those are still rarely reported, but they are very rare. So people who have a lot of allergic problems, can still take the vaccine, but they just need to recognize that they need to be watched a little bit longer in case they have any problems. And all the vaccine distribution sites are ready to manage that problem if necessary.
So there are certain groups we kind of read or not read that they should probably talk to their doctor first before getting the vaccine.
Yeah, some people who have a known history of anaphylaxis, people with severe allergies to food or medications, people whose immune systems are compromised should probably check with their doctor, but typically they should go ahead and get the vaccine. In fact, they should be in the high-risk group and get it sooner than other people. And anybody who might have had any allergy to any of the components of the vaccine. Now, because it's a brand new vaccine and it's different from other vaccines, people, it would be very unusual to know that you're allergic to any of the components at this point.
You mentioned the immune compromise. HIV, people that are on the cocktails and the medication, are they eligible to take it?
Yeah, absolutely. So people with HIV should certainly take this vaccine. Ideally, it's best if they have been on their medication for a little while because their immune system will respond better if their immunity is improved by their medication cocktail.
When you say a little while, a few months?
A couple of months probably, yeah. So if they're a newly diagnosed HIV patient, it's usually best to get their immune system back, working better by putting them on appropriate medication, and then they'll respond better to the vaccine.
Someone that's recently had COVID, should they wait before getting the vaccine? Is there a recommendation? We've heard different numbers.
Yeah, so a person who's had COVID, they only need to wait until they're out of their isolation period, which is typically 10 days.
Really?
Yeah, that's all they need to wait.
And have there been any, you always hear comparable data that could be anything, but are people more prone for some of the reactions if they've had the COVID and get the vaccine?
Yeah, so that's really interesting. So if you have never had COVID, usually you'll have more side effects from your second dose. So with the first dose, your immune system's never seen this before, and it doesn't recognize it at all. And the first dose kind of primes up your immune system. When you see the second dose, then the immune system kind of comes roaring out saying, oh yeah, this is not something we want in us, let's kill it. And it's similar to people who've actually had COVID. So if you've had COVID infection, people have more side effects with the first dose because that's the second time you've seen the virus. So it's the second time you see that virus that you get more of the side effects, the fever, the achiness, fatigue, that sort of stuff. So typically, that's what we're seeing with the vaccines.
And are you seeing a difference in the two vaccines for side effects between Pfizer?
Hardly any. They're very, very similar. Initially, it looked like maybe there was going to be more kind of acute allergic things like anaphylaxis with Pfizer and maybe more late things with Moderna, but as they've been rolled out, they're very, very similar.
Because a lot of us don't know when we're going to be able to take the vaccine. If we're going through our normal doctor's course, some of us might have already had other vaccines, shingles, flu.
Right.
Is there a waiting period we should have before taking?
Yeah, so it's recommended to wait 2 weeks between any other vaccine and the COVID vaccine, and that's mostly because that's what they wrote into the protocol of the clinical trials. They said if you're going to get in this clinical trial, you can't have had another vaccine for 2 weeks. It's mostly just the number they picked. But it sort of makes sense. You don't want to get confused between a side effect from one vaccine and the second vaccine, and it probably gives your immune system a chance to kind of recover from the first vaccine to be ready for the second vaccine.
Would you recommend patients to do anything to maybe mitigate some of the side effects before getting the vaccine?
Right, so I think you should be prepared to take some either Tylenol, acetaminophen, or an anti-inflammatory medicine like Motrin or ibuprofen after you get the dose. After. So there are some studies showing that if you take it before you get the dose, that it might impair your immune system slightly and you won't have as robust a response. Now, that being said, if you have a lot of side effects from the first dose, I do know that some people, including physicians, who've taken a dose before they went in for their second dose, taken a medication to prevent side effects.
But that's not recommended?
That's not recommended. Yeah.
Is there any supplements are that recommended before, again, to boost your system and be ready? Or?
Yeah, I mean, I think the main thing is that, the better health you're in going in, the more likely you will be to respond well to the vaccine. So, we do have some patients who have autoimmune diseases like rheumatoid arthritis and lupus who are on immune suppressing medications. And so our rheumatology doctors are holding some of those medicines for 2 weeks before they get their vaccine. So that's another subgroup of patients who should talk to their doctor before they get the vaccine about what they should do with their medications.
Okay. Is it safe to get the vaccine if you're taking medical marijuana?
Yeah, it should be. I don't see any reason why not.
And if we drop the word medical, it would still be okay. I want to make
That's the only kind there is, right?
What staff person asked you that?
I'm not, it's all anonymous.
If you're a frequent marijuana user, maybe you want to get the vaccine sooner than later because of lung issues, which is where COVID attacks.
Do you expect this to be a yearly vaccine or a booster?
Yeah, that's a really good question. So right now, we don't know the answer to that. So they're following those people in the clinical trials very closely with blood tests every month or so to see how their immunity is doing. So we're about 6 months out now from the first groups that got vaccinated, and they still have very robust immunity against the original COVID strain, which is good. The question is, will we need a booster against the new strains? And so the pharmaceutical companies, including Moderna and Pfizer, are all developing new vaccines that include the other strains. So like with the flu vaccine, every year it has 4 strains. I think what we'll have in a year is boosters that have all the other strains in them, that seem to be clinically important. And I think that's how we're going to get rid of this. Is I think we're ultimately going to need a booster that will include the major strains that seem to be spreading most quickly in the population.
So you mentioned herd immunity, and we've heard all different numbers on what that percentage should be. You probably have an idea of how many people will take the vaccine just by watching your population at TriHealth and some of the others. So one, what is herd immunity? And how many people do you think will get the vaccine as a percentage?
Yeah, so we have some data on that. So herd immunity is when enough of the population is immune to the disease that it just stops spreading and goes away, like measles, like smallpox. We have herd immunity against all of those diseases, and we don't see them unless you go into a population where there's no vaccines, like some Amish populations, for example. And if the disease gets in there, it spreads really fast. With COVID, we don't know what that number is. For measles, it's like 95%. Meaning you got to have really complete coverage because measles is incredibly infectious. So there's a thing called the R naught or the R factor that tells you for every patient who's infected, how many other people will they infect. So the number in measles is 15 to 20. Every measles case will infect 15 to 20 other people who are not immune. With COVID, though, the number is only 2 to 3. So it's not nearly as contagious as measles. So that being said, Tony Fauci, the head of the NIH, who actually is not an infectious disease doc, he's an immunologist, but he basically cut his teeth doing HIV research in the early 80s. And he's a brilliant guy. And so he thinks the number is somewhere between 70 and 85% of the population needs to be immune before COVID will basically stop circulating and go away. I'm hoping that's a little high. And the reason is, within TriHealth, about 60% of all of our employees, maybe a little higher, maybe closer to 65%, have taken the vaccine the first time around. Now, as it's been offered, more people are wanting it, but now they have to wait until their age group comes up because phase 1A is over, and we don't have vaccine for them right now. Interestingly, in the U.S. military, where you'd think they could say you're getting the vaccine, the number is 60% of the U.S. military has taken the vaccine. So I think the number's 60% of people will take it first time around. Now, what happens with time is they see their friends got it, nobody died, nobody had any bad side effects, and then people think, maybe I want to get the vaccine because I don't want to get sick, and they have seen people dying from COVID, which we have seen a lot. So I think, I'm hoping the number's closer to 60 to 65% for herd immunity, but we just don't know yet.
So that's going to be very, very close.
Yeah. Yeah, I mean, if we can get to 70, I think we'll be good. I think it's the people on the fence that we need to convince. I mean, there's going to be some people who just will never take a vaccine because they don't ever take any vaccines. But I think it's the ones who aren't sure yet that we really need to get them over the hump to protect both themselves and our entire community.
And if I ran my numbers right based on adults, we got close to 70% or more for the flu vaccine this year.
Yeah, the flu vaccine uptake was really good, and there's been almost no flu in the whole country. I mean, normally at this time of year we would be, admitting hundreds of patients a day with influenza throughout the state of Ohio, and now there's only like 1 or 2 cases. I mean, it's almost totally gone, which is incredible. Now, obviously, masking, social distancing, all the things we're doing to prevent COVID also work against the flu. So that's one thing. But the second thing is, when you have 2 viruses competing, the one that is more aggressive at transmitting itself will usually win out. And that's what's going on, is COVID has sort of won out. And so that's the one that is much more highly in circulation. Now it'll be interesting to see what happens as COVID goes down. Will the flu pick up again? We're hoping not, because flu is clearly seasonal, whereas COVID is not so seasonal. So we should be getting to the end of the flu season by mid-March.
So I'm going to ask you maybe to put on a couple different hats here, but looking into the future, the short-term future, with warm weather coming up to springtime, with the vaccines rollout continue, what do you see happening in the Cincinnati area?
Yeah.
From an economic standpoint, a safety standpoint, the whole.
I mean, I think as the numbers go down, and hopefully they will, but I will say that there's a guy named Michael Osterholm. You see him interviewed on CNN all the time, who's the state epidemiologist in Minnesota, who's a brilliant guy. He's been predicting a massive pandemic for many years now, that we would have one of these, and a lot of people have thought so. He says the next 3 months are going to be the worst of the entire pandemic as these variants take over and start to spread, and people who have previously had COVID won't be immune, and we're going to be right back where we were. I hope he's wrong. I think he is wrong, but we'll just have to see.
The wild card being the vaccines with the elderly population.
Right.
And
Yep. Right. Yep. So if you got the vaccine and you live in a nursing home, you're well protected against the original strain. But if these variants, which maybe are not so well prevented by our current vaccine, get into the nursing homes, it's possible we could be right back where we were, in the middle of December and early January. So that being said, I think we're all going to be wearing masks until late in the summer, because we just don't have enough vaccine to vaccinate the population. I mean, right now,
even the 60% number that we think.
yeah, we're not going to be anywhere near 60% till mid to late summer, just because there's just not enough vaccine. So right now at TriHealth, we could vaccinate 6,000 people a day, and we get 1,000 doses a week, which there's a big gap there. And when we first, started rolling out our vaccine program, we knew we had 30,000 patients older than age 80 that we needed to vaccinate, and most of whom wanted the vaccine. So that's the other thing that's interesting. The higher risk you are of getting a bad outcome from the disease, the more likely you are to want vaccine, which is not surprising. So we're still trying to get to our over 80-year-olds, even though the state says we can vaccinate people down to age 65. Just because it's hard to, we just don't have enough vaccine. So.
And what's the best way, if you're in those groups now, to get the vaccine?
Yeah, so there's a number of different ways. All the health systems in town have websites that you can go on and sign up. The health department also has a website. So if you're in Hamilton County, you can go to Hamilton County Health Department. The Cincinnati Health Collaborative, which is a coalition of hospitals in the health department, also has websites and phone numbers on their web pages that you can call. And then the state of Ohio is actually developing a statewide system for signing up that you put in your zip code, and it'll tell you where you can go to get a vaccine. Now that's not up and running yet. So what they're trying to do right now is build bridges between all the hospital information systems and the state information systems, so that information can flow across. So we can let them know, yeah, we have 100 vaccines at this site, we can take 100 people. Mercy can take 100 people over there. It's a big task to build this electronic information system that will be seamless, but that's what we need.
And it was reported the states is supposed to be ready within 2 weeks, is that right?
That's what they're saying.
Okay, so you're not.
I'm not convinced.
And that's supposed to be a single site to go to, and then from there it'll connect you.
Correct, yep. And I think the state will have their site up, but it's the connections I'm more worried about. Because right now it's each individual provider. Walgreens has got one, Kroger's has got one, TriHealth's got one, Mercy's got one, but none of them are connected. So the connections are always the trick.
Hit all my questions.
All right.
Thank you so much.
Yeah, sure. Yeah.
I've got a question or two. So, heard that, or had a young person kind of say that she's not going to get it for the fear that she can't get pregnant in the future.
Right. So, two things on that. The first is that in the original vaccine trials, a number of young women did get pregnant while they were in the trial, meaning they'd gotten one vaccine, they got pregnant, they went ahead and got the second vaccine. There have been no adverse outcomes in all those women. And the second is that the American College of OBGYN and the Maternal Fetal Medicine Society have all come out recommending that pregnant women should get this vaccine, and it is safe in pregnancy as best we can tell. And the reason is that COVID is a bad disease in pregnancy. We've had some young women in our ICU on ventilators for months, because when you're pregnant, you're relatively immune suppressed. And if you get COVID when you're pregnant, that's when we see bad outcomes. So the vaccine seems to be quite safe. Now, ideally, it's probably best to get it before you get pregnant, then you don't have to worry about it. But you know, since we don't have enough vaccine, it's harder to plan right now. And ultimately, most of the obstetrics specialists are recommending to go ahead and get it, even if you're pregnant.
Well, what the fear was in the future.
It does nothing to your fertility. Yeah, that was some internet, hogwash.
Right.
Yeah.
Great. Secondly, if you get the vaccine, okay, not have to wear a mask. What happens at that point? What are we supposed to do at that point? What is that person free to do?
Okay.
How does their behavior change?
Yeah. So their behavior shouldn't change yet. Although there is one nice advantage is if you get currently, if you're not vaccinated and you get exposed to COVID, you have to go into quarantine for 14 days. I mean, you got to stay home from work. You can't be out in public. You just got to stay home. But the CDC just came out in the last week and said if you are fully vaccinated and you get exposed to COVID, that you don't have to go into quarantine. So that is a nice advantage that should be a great benefit if you're vaccinated. Eventually, a lot of people are talking about what's called an immunity passport. That you do get a little card now when you get your vaccine, and it says you've had your 2 doses and what dates. That eventually, if you want to go to the ball game, you want to go to the movies, you want to get on an airplane, if you don't have that, you're not in. And I think that will be one way that will encourage people to get their vaccines, is by the limitations on unvaccinated people. So,
Can I ask a question
yeah.
to follow up on that? So one of the things we're thinking here in our club, particularly as you mentioned, some of the vulnerable populations have been quarantined, locked up for such a long time, some self-imposed, but for their safety. And a big part of our component of wellness was social. We believe that was an important part of everyone's wellness. If we had a vaccine-only party where people could only come if they were vaccinated, would you consider that to be a safe environment and reasonable?
At some point, yes. I'm not sure we're quite there yet. But I think probably maybe by summer. And now we would probably still encourage people to wear masks. So one big question that we don't know the answer to yet, but we're starting to get there, is if you've been fully vaccinated, could you get a low-grade asymptomatic infection and still be able to pass it on, even though you have no symptoms? So that data is starting to come out. And so for the AstraZeneca vaccine, which is the one that they're using predominantly in the UK, looks like it's very difficult for those people to get any infection or pass it on. And I think Pfizer just came out with their data showing that if you've been fully vaccinated, it's very, very unlikely that you can pass the disease on. We need more studies to prove that, and I think once we get that, then that will make sense, that if you had all vaccinated people, you could have meetings, you could have parties, you could do things together.
We might know that in the next few months.
I would hope, yeah.
And by the way, when we're thinking about these social activities coming up, it would be outside.
Yeah, that would always be better. Yeah,
You mentioned on the vaccine some of the side effects. if you get the fever from the vaccine, should you quarantine yourself during that period?
So the current recommendation is if the fever is within 48 hours of the vaccine, you don't need to. But if it lasts longer than 48 hours, then you should maybe get a COVID test to prove that you didn't get COVID right around the same time you got your vaccine. So there, in the clinical trials, and we've even seen a few cases here in Cincinnati of people who got COVID between their first and second dose, because the first dose doesn't give you complete immunity yet. It's usually within 1 week of the first dose. It's very rare for that to occur after the first week following the first dose, because it's about 7 to 10 days when you start building antibodies. But for the first week after the vaccine, you're not going to have enough immunity to protect yourself from COVID.
So when you go back to the herd immunity, is somebody who's gotten the vaccine equal to somebody who's actually already contracted the disease and had COVID?
Yeah, probably not. So the vaccines give you much higher antibody levels than the natural disease for most of the people that have been studied. It's that second dose that really boosts up your immunity, that kind of gives you the high levels of antibodies that we think you need to protect yourself from infection. Originally, it looked like maybe natural immunity was only going to last about 3 months, but some new studies are coming out suggesting maybe it's as long as 6 months. But we know from other coronaviruses that natural infection does not lead to long-lasting immunity. So there are what we call seasonal coronaviruses, that causes of the common cold, not nearly as severe as COVID-19, but people can get those coronaviruses over and over again. They're kind of like a severe common cold. And we suspect the same thing would be with COVID-19, is that you're immune for a while, but you could still get it down the road. So the goal of the vaccine is to give you more permanent immunity. And whether that'll involve a booster at 1 year or 5 years, we don't know yet.
Can you talk a little bit about the one-dose shots that are coming out?
Yeah, so there's a new vaccine from Johnson & Johnson that was just, the data was just submitted to the FDA, the Food and Drug Administration, for emergency use authorization. The FDA is reviewing that data, and they will have a meeting on the 26th of February to determine if they're going to approve that vaccine. Based on what we know, it's very likely that it will be approved shortly after that. And so that the beauty of that is two things. One, it's a single dose. And two, it can be stored in a regular refrigerator for like 3 months. Whereas the mRNA vaccines from Moderna and Pfizer have to be kept at very, very cold temperatures. They're a lot harder to distribute. The logistics of distribution is much more difficult. Whereas the Johnson & Johnson vaccine could be in your doc's office. But your doc doesn't have the kind of freezers that they need for the mRNA vaccines. So now the question is, how long does that one dose last? And so Johnson & Johnson is doing a second part of the trial that's a second dose booster. So they'll follow all those people who got the first dose, and if it looks like they are losing their antibodies after a period of months, then they'll have data on a second dose to determine if they really would need a second dose.
And the efficacy isn't quite as high as it is in the other two.
It's not quite, but it's really good. It's at least 70 to 85%. It's probably 85 to 90% against severe disease, but maybe only 70% in preventing mild disease. But it's still really, really good. I mean, you think about the flu vaccine some years is only about 30%. So those all the COVID vaccines are way better than the flu vaccine. Anything else?
Is there anything we didn't ask that you said in this group you should have asked this question?
No, you guys, those are great questions. All really good questions. So in my mind, a few questions that I still have is, so what are we going to do about the variants? And how much effectiveness does a vaccine need to be to be of any value. So the FDA says it has to be at least 50% effective or they won't approve it. So that seems reasonable. And then which of the variants that are out there are most important that should be put into the new vaccines? And we've got to do a much better job in this country tracking those variants, which we have not done as well as the United Kingdom and some other places around the world. Our public health infrastructure has not been adequately funded over the years, and we're learning that now because we just don't have the kind of contact tracing we should have had all along, and we don't have the lab facilities to do the kinds of testing of these viruses to identify the variants. But looks like there's more funding coming up for that, so hopefully we'll catch up. The good thing about the U.S. is if somebody's going to pay for it, it'll get done. So we'll catch up. It'll be good. Yep. All right. So, I mean, if you guys have other questions, you can get them to Katie or you can email them to me, and we'll get them answered.
Oh, I've got one more.
Yeah.
This is the business side. So any other recommendations you would have in the health club industry? Because there's been a lot of data, good data, around the world and the U.S. that we aren't, the health club industry is not one of the spreaders at all.
So I think that you guys were on top of it with social distancing really early, and then the kinds of things that you have done with your air turnover is really important for a respiratory disease. And I'm sure there's lots of checking before you can even get in the door to keep sick people out. So I think all of those things that you've done have been really important. Fortunately, it turns out this virus is probably not that easy to spread by surfaces. Although I'm sure you do lots of surface cleaning here, but that's not the primary way it's spread. So all the things that you do to increase air exchanges and keep people socially distanced are critical. So.
Okay, I got a question. I'm going to put you on a test with it. Of all the demographics that come in here, which group do you think is the hardest to distance, to keep distanced?
I guess I'm going to say 20-year-olds. Yeah, I mean, they're just not worried about it. Because if they get it, they get it, and they get over it. And that's true. And I bet the old folks are really...
Tell me what they're saying about that.
What? Oh, I
when they see a 20-year-old...
They run away, probably.
Yeah.
But I mean, I bet your older folks follow every rule to the T. So
We
I
have a
don't...
6-foot stick we actually carry around
Really?
all the time. Yeah, it really helps.
Yeah, good. That's a great idea. Yeah. Do you have any special times for the older folks?
We do.
Okay. Yeah.
Those and those that are compromised.
Okay. Yeah. That's fine.
Tuesdays and Thursdays mornings, isn't it, Phil?
Yeah.
Yeah.
Yeah, I think that makes people feel a lot more comfortable.
And we don't require masks when you're exercising. The WHO and both CDC has had studies on that for years before this.
Yeah.
And the risk that's associated. Some people can, but other people it's very hard on them.
Yeah.
And however, we do have some classes, think of some of our yoga classes and some of our meditation where we have masks required to give people some comfort if they want to be in those rooms.
Yeah, that's a good idea. Yeah. Yeah, basically health clubs and gyms have just not been events other than college sports teams, which are a different animal. Those are contact sports mostly, and so that's a different scenario. I mean, it's mostly bars and the Rose Garden, where things happen.
The bars, yeah.
The bars, yeah.
And we've noticed, I've read some of the transitions time. We let our guard down. So it's maybe going and coming to places, and it's in those exits and entrances where the people will...
We would gather outside, maybe take their mask off to get a breath of fresh air. Yeah. And big family gatherings. I mean, I have some cases right now where the family said, "Yeah, we thought we were good, and we had 25 people over for Christmas, and they all got it." So
really,
all of them. Yeah.
Home HVAC systems are probably the worst ones we'll ever be around.
Yeah.
No fresh air.
Yeah. Well,
Unless you open a window.
Yeah, unless you open a window. Yeah.
And run your fans all the time.
Yeah. In the wintertime, people don't normally do that. So, yeah. Yeah, you do. Yep. So, but I think we're going to get through it, but I'm afraid it's later than I was hoping. I think we're looking at late summer, fall before we can start thinking about herd immunity.
Thank you.
All right. Thank you. Yeah. Appreciate the opportunity.